Here at ASCO, there were 4 positive clinical trials of targeted therapies for hematologic disease, and in this case, we are talking about a new agent called Daratumumab, and I am with Dr. Saad Usmani, who is an MD, Carolinas Healthcare System in Charlotte, and the Levine Cancer Institute there, where you're the Director of Plasma Cell Disorders and the Director of Clinical Research in hematologic malignancies. This is a brand new agent, correct?
That is correct.
Talk about it a little bit. Give me some idea of what it is.
Daratumumab is a human monoclonal antibody. It targets CD38, which is a surface marker on myeloma cells, and it's highly expressed. What Daratumumab does is kill the myeloma cells by various mechanisms, by engaging the immune system, and also has the capability of killing the myeloma cell by itself. So it has direct cell death mechanisms as well as immune-mediated cell death mechanisms that it relies on to kill myeloma cells.
It's always exciting when we talk about a positive trial, and this is certainly one of them. Give me a little idea of who the patients were who you enrolled in this.
This was a phase 2 trial for relapsed refractory myeloma patients who have had at least 3 prior lines of therapy, or who are double refractory. We use the term double refractory for patients who have been refractory to both proteasome inhibitors and immunomodulatory drugs. It is an area of unmet clinical need. We do run out of options for those patients, and even if they're in good physical shape, it's difficult to have that discussion with patients. So it is an area of clinical need. We have seen a big boom in immunotherapies being developed for several solid tumors as well as heme malignancies, and Daratumumab is an exciting addition to the armamentarium for myeloma physicians.
So talk about the treatment itself and then the results.
The trial was designed as a multi-center international open-label phase 2 study. In the initial part of the trial, 2 different doses were utilized, the 8 milligram per kilogram dose and the 16 milligram per kilogram dose in 18 and 16 patients respectively to see the efficacy. And the 16 milligram per kilogram dose was deemed to be more efficacious, and 90 additional patients were treated for a grand total of 106 patients. These patients had a median of 5 prior lines of therapy. So this was a heavily pretreated patient population. Vast majority of patients were refractory to both proteasome inhibitor and immunomodulatory drugs, bortezomib and lenalidomide. Almost half of the patients had either been exposed to or refractory to carfilzomib and pomalidomide. So this was a truly refractory patient population. What we found was that Daratumumab is an effective drug and it's a safe drug. What we found was an overall response rate of 29%. So 1 out of 3 patients, roughly 1 out of 3 patients who were treated on the study had at least 50% decrease in their myeloma protein levels. And that was quite impressive for a single agent of this nature. What was also impressive was the fact that we saw that 3% of the patients had a stringent complete response, which means disappearance of the monoclonal antibody and normalization of their free light chain ratio, along with absence of clonal plasma cells on a bone marrow biopsy. So that's unprecedented for an immune therapy of this nature for this heavily pretreated patient population. What's also encouraging is the fact that its safety profile is fantastic. The main side effect that we see is infusion-related reactions, but those reactions are mild, only grade 1 and 2. They usually happen with the first infusion, and they can be managed with standard of care measures. They do not occur again, and the patients can tolerate this therapy very well with subsequent treatments.
Now, there are already some ongoing phase 3 clinical trials?
That is correct. So based on the encouraging safety profile and responses, on 5 big phase 3 studies have been planned in newly diagnosed patients as well as in the first relapsed setting. And Daratumumab is being combined with available anti-myeloma treatment platforms to see if we can improve on the efficacy of those platforms without adding toxicity. That is the major advantage of having this kind of immunotherapy or monoclonal antibody, that you can potentially add to the patient's depth of response and survival outcomes without causing them grief with side effects.
Well, congratulations. It's an exciting trial.
All right, thank you.
And we have a variety of other trials that we've talked about here that are very positive, so please look around for those. For ASH Clinical News, I'm Rick McGuire here in Chicago.